Welcome my friends, brothers and colleagues from the medical career. Welcome to this your channel, Clinical Consultant. Previously we were talking about breast abscess. I will leave you the link in the description so that you can see it. This time we will be talking about the pelvic abscess. A subject that every doctor and medical student cannot pass on since mishandling would lead to the death of the patient. I insist that if you want to delve a little deeper into this subject, consult your medical texts. Then let's continue with the video. As a concept we have that a pelvic abscess is an acute or chronic infection that affects the pelvic viscera and that at first it is localized, and this little biliteral is generating its own environment that is unique and its own, so the form of treatment and healing requires strong treatment. This is also known as tubo-ovarian abscess or abscess of the vaginal ring. They could be different classifications, but that depends on the author. In the etiology, according to the etiological factors, we have 4 categories. The first one is an ascending infection, which spreads from the cervix through the endometrial cavity, towards the adnexa, originating a complex called the tubo-ovarian complex. The second of them is an infection that occurs during the proprium, which spreads to the adnexa from the endometrium or myometrium, but the difference of this is that it spreads through hematogenous or lymphatic life. The third category is an infection that is complicated by pelvic surgery. And finally, it is a condition of the secondary pelvic viscers. It is a dissemination of contiguous organs, that is, they may be due to appendicitis or diverticulitis. Let's recap. The first is given through the endometrial cavity. The second is given by hematogenous and lymphatic life. The third for surgical complications. And the fourth for common diseases of the pelvis such as appendicitis and diverticulitis. In its epidemiology, we have that this disease is given by 34% of women hospitalized for PID bone due to pelvic inflammatory disease. 102% of patients underwent hysterectomy, especially via the vaginal route. Its highest incidence generally occurs among women who are between their 3rd and 4th decades of life. It is important to say that between 25,150% are nullipers, that is, they have not had children. Among its risk factors, we have the same risk factors for PID, although 30,150% of patients have no history of having suffered from self-inguinus before the abscess occurred. Between its signs and its symptoms we have abdominal or pelvic pain in 90% of cases, bone in most, fever and chills in half of all cases, abnormal bleeding in 21% of all cases, vaginal discharge in 28% of all cases, nausea and vomiting on the 26th. And it is important to say that up to 60,180% of all cases do not have fever or leukocytosis. That is, it means that a large part of women are semi-symptomatic. In its etiology, what we can see is a very varied flora between anaerobes, aerobes and facultative anaerobes such as E. coli, B. fragilis, Prevotella spp, anaerobic streptococci, Peptococcus, Peptostreptococcus. It must also be said that the main agents in cervicitis and salpingitis are Neisseria gonorrhea and chlamydia, but it is rarely cultured in the abscess cavity. In addition, we must always raise the possibility of diverticulitis in elderly women. In the differential diagnosis, we must always rule out the existence of pelvic neoplasms. Soon I will be talking about neoplasms in future videos. Among the pelvic neoplasms that we must rule out are ovarian tumors and lymphoma. In addition to non-inflammatory masses that affect the intestine or the adjacent omentum, such as appendicitis or perforated diverticulitis. In addition to pelvic hematomas that are complications of caesarean sections or hysterectomy. It is very vital to tell you that the most common cause of death in this pelvic abscess is when the doctor delays the diagnosis. Among some tests, ultrasound or computerized tomography is usually used, this because the pain of the patient makes it difficult to carry out the physical examination since it is pain that causes an abdominal defense that hardens the wall of the abdomen. In the laboratory tests we can perform a complete blood count, including leukocytes with a respective differential count, HB and HT. Cultures for aerobic, anaerobic and facultative anaerobic germs of the cervix, blood, urine, sputum, the peritoneal cavity, if necessary, and the abscess cavity should be performed before receiving antibiotic therapy. It will be necessary to do a pregnancy test in women of fertile age, this in case there is a risk of pregnancy. In the diagnosis by images we have 1. An ultrasound. This test has the advantage of being cheap and not very invasive, and this is used to confirm the diagnosis. It has a high sensitivity of 90%. 2. A computed tomography is used to make a diagnosis and give a treatment, that is, to make a drainage under the control of the computed tomography. 3. The main focus of use is when the ultrasound provided little information, as an example that I put there of pelvic abscess versus intra-abdominal abscess. 4. Last but not least, and it is important to say that the frequency of successful drainage will depend on the focus and its quantity. In nuclear focus it has a 90% success rate, while in multilocular abscess it has a 40% probability of success. I mean less than half. During the treatment we have two major concerns, one of which is the desire for future fertility by the mother or relatives. And the second, the possibility of rupture of the abscess that could give more serious complications such as peritonitis, septic shock, and some irreversible sequelae that could damage the life of the patient. Acute treatment. During acute treatment, we have to decide whether the patient requires immediate surgery when we suspect a rupture, or whether to treat it with intravenous antibiotics. It must be understood that a poor response to medical treatment occurs in patients with axial masses more than 8 cm, bilateral disease, or when the patient has compromised immune function. The antibiotic combinations that we use the most are clindamycin 900 mg intravenously every 8 hours, or metronidazole 500 mg intravenously every 6 hours or every 8 hours, plus gentamicin in doses 5 to 7 mg per kilogram per day, or 1.5 mg per kilogram every 8 hours. Some alternatives we have are using ampicillin solvatam 3 grams intravenously every 6 hours, or ceftin 2 grams intravenously every 12 hours plus doxycycline 100 mg intravenously every 12 hours. It is important to say that some of these drugs do not exist in some countries, and they should consult their pharmacology texts to use other alternatives. During medical treatment, a high suspicion that we have a rupture of the abscess, giving signs and symptoms such as acute worsening of abdominal pain or a recent onset tachycardia accompanied by hypotension, will require immediate surgery after we are stabilized. To the patient, we have 3 surgical options. 1. A laparoscopy with drainage and irrigation. 2. Transvaginal colpostomy. The abscess must have certain conditions to take this option as it is. The abscess must be in the midline, dissect the rectovaginal septum, and be attached to the vaginal fornix. 3. As a third option, we have laparoscopy including total abdominal hysterectomy with bilateral or unilateral salpingo-oophorectomy. As a forecast we can say that of 100% of the patients treated immediately, 75% respond to a pregnancy frequency of 50%. The absence of response occurs in 30,140%. They can be treated by a controlled drainage with a computed tomography or a surgical intervention, clearly remembering that unilateral appendectomy can achieve the same healing results as a hysterectomy, and that it has the advantage of preserving reproductive capacity in women. Referral. If the patient has ATO, she should be referred to the gynecologist. As comments I can tell you that if actinomyces is isolated in the culture, the treatment with penicillin will need to be for a longer time, between 6 weeks and 3 months. Thank you very much, because thanks to you we are almost 50 clinical consultants. Let's keep going. Thanks for watching the video. I hope you like it and subscribe in case you haven't. Next topic, prerectal abscess. God bless you.